Welcome to the OPENPediatrics Nursing World Shared Practices Forum. My name is Christine Rachwal. I'm a Master's Repair Clinical Nurse Specialist in the Cardiac Intensive Care Unit at Boston Children's Hospital. In addition, I serve as faculty for the Program to Enhance Relational and Communication Skills, PERCS, within the Institute for Professional and Ethical Practice. With me today is Professor Jos Latour. Professor Latour has been a pediatric and neonatal intensive care nurse for nearly 30 years. Throughout his career, Professor Latour has developed an extensive research background and published widely on various topics related to patient and parent empowerment in care, as well as end-of-life care practices, pediatric sepsis, and transition of adolescents with chronic illness from pediatrics to the adult care realm. He is an associate editor of Pediatric Critical Care Medicine and editorial board member of several other international peer-reviewed journals. Internationally, Professor Latour has been active in a number of societies and was additionally honored with several awards, such as the Fellowship of European Federation Critical Care Nursing Associations in 2008, the European Society for Pediatric and Neonatal Intensive Care Lifetime Achievement Award in 2009, and 3 Presidential Citation Awards of the Society of Critical Care Medicine. Currently, Professor Latour is clinically based at Derriford Hospital in Plymouth and Musgrove Park Hospital in Taunton, UK. In this post, he is leading the clinical schools to enable research translation into clinical practice, build research capacity, and develop and value a research culture in clinical settings. So Professor Latour, welcome. Tell me, what led you to your interest and involvement in the end-of-life care issues?
Well, what's happening about 30 years ago when I started working in the Pediatric Intensive Care Unit, a couple of events happened. The first one was actually where we stopped the treatment, i.e. the ventilation of a child, where the parents were not involved, they were not present. And while stopping the treatment, I suddenly said to the consultant and my colleague nurse, Can I have this child on my lap, because I can't just stand here and see how this child is dying in bed without the parents. So that was quite an emotional experience for me. And the second event happened, what happened fairly soon after that was when the parents called me in my night shift. I had to give them the blood results, and the parents said, you know what, this is it. We crossed the line here. I just want to have a multidisciplinary talk. And I agree with the parents, and I organized in the middle of the night a multidisciplinary talk where we actually sit together with the consultants, the pediatricians, the nurses, and the parents, where the parents decided to stop the treatment. So looking at these two events, what occurred quite closely in time perspective, is that I thought, are we doing the right thing? Why are these two events so different? And what were actually the needs of the parents? Because they were different. So that led me to quite an interest in what's happening, how can we improve the care, and do we deliver the care according to the wishes and needs of the parents?
So with your extensive experience in this area, what do you see as current priorities in end-of-life care today?
Well, I have my personal opinion, but let's go back, because a couple of studies we've done, I was involved in. There's one study where we look at the priorities within pediatric intensive care nurses. It's a large European survey study where actually the top priority for all nurses working in PICU, and there were about 70 or 80 experts participating in this Delphi study, is that improving end-of-life palliative care for children was the top priority. But it also comes back to the second highest priority, where communicating and decision-making processes around the care of foregoing and sustaining life treatment decisions is one major topic. Now, that was a European study, and I believe the next study we've done during the World Congress in Istanbul in 2014 is another group of experts actually rated the facing the death of end-of-life decision-making and what nursing interventions directly impact on the child and the family as the most top priority in nursing research. So from a personal perspective, I would completely agree with the studies we've done among all these experts in Europe and in the world. But I also think there's looking at the scientific evidence up till today is that we started off about 10-15 years ago, several groups around the world looking and exploring at what's happening around end-of-life decision-making. That is often like qualitative studies, looking at the individual needs of parents. We've done also a European survey about what are the views of the nurses about end-of-life care. So they were all explorative studies. Now, I think last year at a certain point when I started looking at, so tell me what kind of interventions are appropriate for us nurses to look at to improve actually the end-of-life care. From a nursing perspective, I realized that there were very, very limited interventional studies that are published. And I think that is one of the top priorities for us. We have enough explorative studies. We know what parents want around the world, or at least in most countries in the world. We got quite a number of studies what parents want. We know what the perspectives and the experiences of our staff, of our nurses are in terms of involvement of end-of-life decision-making and the whole process. What do they have to do? But I think we need to look at good intervention studies and evaluate them.
Wonderful. So, interestingly, bringing it back to all of the different work that was done across Europe, how do you see the needs varying cross-culturally among families at end of life? And how do we determine as clinicians what the best methods are to meet those needs?
Right. The first question is, how do needs vary across cultural settings, or the cross-cultural, intercultural needs of families? I do recall a study that interviewed 56 parents, and they identified 6 priority areas. One is honest and complete information. The second one is ready access to staff. The third one is communication and care coordination. The fourth one was the emotional expression and support of staff. And the fifth is preservation of the integrity of the patient-child, the parent-child relationship. And the last one was faith. Now, looking at these 6 major priority areas, these remind me a lot on explorative qualitative studies about the needs of parents in the intensive care, where the number one always among like 8 or 9 studies I'm aware of, that honesty and correct information giving at the correct time are the top priorities. So I believe there's a challenge, because the question from you is about the intercultural or the cultural differences. Right. That is often neglected in many studies. The studies are based from many, we know, from the US or Europe, but we have little knowledge how parents in Asia actually define their priorities, define their needs. Are they included in end-of-life processes when it starts with the discussion about life treatment, yes or not? Because I recall I just came back from China last week, where I heard that parents do have to make a decision in the neonatology intensive care concerning life treatment if they can't pay. So if parents can't pay, they ultimately make a decision to stop a treatment because there's no financial backup for them. So this definitely not happen in Europe, and possibly definitely not in the US, because we try to find funding to pay treatment for those children when we see that the treatment would be very helpful for the child. So in terms of a world perspective, I would say there's a lot of intercultural impact on parents which we don't yet know, and it's not out there in the literature as well. The second question is that how can the bedside nurses best determine those meeting those needs? I think there's a couple of arguments for that. I always address to my colleagues in the PICU that we have to assess upon admission already the needs and wishes of parents and document that and communicate that among the all team members. It's not only about their involvement in difficult decision making, but it's rather their involvement of care, the involvement of communication levels. It comes close actually to the philosophy of family-centered care issues, where you would like to include the parents in the care, but not only care, but in difficult decision-making processes as well. Now, the other argument, I believe, is that it should be multidisciplinary. We nurses tend to sort of overrule and overview the whole process of caring for the family. But there's a variety of services in the US, in Europe, and in Asia, where I learned, for example, in the US that there's an increasing number of palliative care teams now in the PICU available. Well, in Europe, I wouldn't say there's no, but that would be very limited availability of palliative care teams in the PICU. But if possible, yeah, we should try to establish palliative care teams in the PICU. However, we do have, luckily, and I think we should communicate and collaborate with the psychologists, social support workers, pastoral care, and even sometimes invite ethicists into the discussions.
So we've spoken a little bit around cultural challenges and some things that you faced already with end of life, but what do you see as challenges that we in the healthcare community face around end of life care today?
That's an intriguing question. Thank you very much, Chris. And I think there are lots of challenges for us. There is in the world an increasing cultural diversity among patients and families, what we experience, and that implicates actually the shared decision versus informed decision model. What I like to address is the autonomy of parents. There are the challenges across the world and even within countries. The challenge is actually the level of autonomy where you would include the parents even making a decision about end-of-life care, yes or not. And as far as I understand, in the US system, it's a very shared decision-making model where parents would possibly often, I would say often, make this ultimate decision. Now, if you go back to cross the ocean to Europe, there are laws where it would say the doctor is the ultimate decision-making about end-of-life care. That's incorporated in the law in many European countries. Now, if you then cross to the Asian countries, as I addressed just before, is that parents sometimes have to make the decision due to financial constraints. But that varies a lot, what I learned, because China, I mean, it's a 1.3 billion Chinese living in one country, so there's a lot of variation going on, even between NICU and the PICU. So that is the mingle and the mixture of all the cultures within Europe and in the US is a challenge. I mean, I acknowledge actually that in the US you have got an enormous diversity, and this diversity of family members may implicate also a diversity of their own wishes. I think the other challenge is that what I call partnering with parents. The family-centered care principles are coming into place here very much. Well, one of the interventions we used to do already for 20 years in the Netherlands, and in some PICUs in the UK, is to provide parents a diary, and have them written down how they feel, what they experience during the PICU, as well as nurses and doctors in layman language write down what is going on with a child. And particularly we use that for long-term patients in the ICU. And I think providing parents a tool that gives them not only during the course of the PICU any sort of support and supportive help. Because what I experienced when I ride in the night shift, hi little John, I had to wake you up because you need endotracheal suctioning during the ventilation, but you went to sleep directly, lovely, so everything went fine. If I write this little layman language quote, parents when they come in the morning, the first thing they do is take the diary and just start reading. That acknowledge actually, well, it's not acknowledging, it's more we partner with them and tell them actually how it's going on. Well, there's another challenge which I believe which is difficult and comes back to the cultural issues, the coping strategies. Parents have different coping strategies, and I think we should train ourselves and all new nurses and even the established nurses in various coping strategies, particularly when it comes to end-of-life care issues or the death of a child. I addressed before a bit like intervention studies are needed. That's another challenge, because if you do intervention studies, you wouldn't need validated instruments to evaluate the intervention. Now, the challenge for us now is that we don't have enough tools available that are validated. Now, I know there's the PICU QODD, that's the PICU quality of death and dying, and that is a validated instrument that really, it's a 20-item instrument that's really rigorously developed and tested. So that's one instrument, and I think the group of Kathleen Meert developed another validated instrument evaluating the bereavement levels of parents. So there are gradually, since the last 4 years, instruments coming in where we can then have a rigorous intervention study to test these new interventions. Another challenge is, we all know, I mean, mortality rates in PICU range between 3 to 5% in the US and in the UK, as well as in Europe. Or more, our PICU databases show this. But what's happening is, because it's just a small number of cases, we experience this kind of end-of-life care practices is where we, I don't know, it's possibly the impact it has on not only the parents, but the impact on us nurses. And I think we nurses, we try to do our utmost best to deliver the highest quality of support and care to the parents, and therefore most practices, what we do in end-of-life care is highly valued by the parents. Another challenge, what I would believe, is developing bereavement support groups for parents. If you look at the pathway of the child from full treatment to end-of-life care, is that the bereavement support group comes almost at the end of the pathway. Now, it might be interesting to, one of the challenges is to organize follow-up care meetings with the parents. And as we done in the Netherlands and in the UK, it's a nurse-led follow-up care, what we do with parents. So 6 weeks after the child died in the PICU, the parents are invited to come back to the hospital and to review the whole process of the care. It has never been evaluated, but I know there's a study came out last year in critical care medicine, which was actually a physician-parent follow-up meeting, which was highly valued by the parents and as well as by the physicians. So what they've done is, the intervention was a training program for physicians. How do you organize, how do you communicate with parents during a follow-up meeting? And then it was measured, I think in about 30 plus follow-up meetings that were evaluated where parents were very pleased. So that is a challenge, whether we should sort of look at that. In neonatology, actually, was where we've done a world survey. 80% of the 117 participating NICUs from 36 countries worldwide, 80% do organize face-to-face follow-up meetings for parents. So in terms of a world perspective, I do believe we do have quite a number of very good interventions that have been that are taking place, but the funny thing, we don't share it that much in the literature. I mean, we share it among conferences, we share it in this OPENPediatrics discussion forum, but we can learn more from each other to improve the care.
Yeah. So it sounds like one challenge is that we really need to start looking at it and also putting it into writing.
Right, yes.
I'd like to turn now to the audience to ask our colleagues around the world a question. When you reply, could you please state your city and country location? The question is this: what are the spiritual and religious needs of parents when facing difficult decisions in your country? And we're back now with Professor Latour. What role do you see nurses playing in facing these challenges?
That's a very interesting question, because I think we should be more anticipating. But let me first refer back to a study we've done. It's a European study about the views of nurses, critical care nurses, and their role in end-of-life care practices, where we saw that in their perspective is that the timing of end-of-life discussion was just right, was that 53% of the nurses said, well, no, I disagree, it's not right. And the next question was actually the timing of end-of-life discussion is often too late, where that 60% of the nurses, and that was a survey with around 160 nurses, 60% of the European nurses said, well, it is often too late. Now, are they always actively involved in end-of-life discussion with the physicians? Is that half of them, they would say, yes, I strongly agree, and half of them, they would say, no, I disagree. So there's in terms of the role, I believe we should be more proactive, and as I said, it should be multidisciplinary. Any discussion from the first moment on when treatment is discussed, whether it's optimal or not optimal, or whether we should stop a treatment or withhold a treatment, I think the nurses should be involved. And often you might have the opportunity of that the nurse would then, while being involved in the discussion without the parents, the nurse can on the bedside support the parents much more better when they are fully informed about the difficult decision. So I think the support system for the nurses and the role what they have to play in the PICU among difficult decision-making processes is a very important. The funny thing is that when we asked the nurses in the survey we done in 2009, would the level of involvement in end-of-life decisions positively influence your job satisfaction? Now, 72% say, yeah, it does positively affect my job satisfaction. So somehow it's not only something nurses should do, it's almost a compulsory act we have to do during our clinical work.
So how do we encourage nurses, for those that don't feel they're empowered to participate in these discussions, how do we encourage nurses to become a part of that?
Yeah, I think if you look at the workforce we have in the PICU, you've got very experienced PICU nurses, and you've got the new staff coming in. Basically, depending on the country where you are, you have to have a pediatric intensive care postgraduate training. Now, regardless the training is there on a national level, I think end-of-life decisions and involvement and end-of-life care and intercultural communication with parents, these topics should be included in the educational program. Now, the countries which does not have these postgraduate training, I would strongly suggest that that workshops will be organized for the junior staff to become more empowered to be included in end-of-life discussion, because it's a skill, but it's also something empathic you have to learn, because there's a lot of empathy coming into the communication with parents. There's a lot of learning to how to argue your patient with the doctor. That's a skill as well, and I think these skills needs to be developed in an ongoing training program in every PICU and NICU.
I'd like to turn now to the audience to ask our colleagues around the world a question. When you reply, could you please state your city and country location? The question is this: are nurses involved in end-of-life discussions with doctors in your intensive care unit? And we rejoin our conversation with Professor Latour. I'm interested to know if we've asked families the importance of nursing being involved with these discussions and whether there's been an impact there, because we do look at things as an interdisciplinary team, and wondering where the family fits in with this. I mean, is this something that they're asking for? Has anyone looked at that?
I think parents are more empowered these days. Now, what's happening for example, in Europe, I really need to address this. There's the European Foundation of the Care of Newborns and Infants. It's a parental organization. It's a federation of over 30 national parental organizations. Now, what they've done, have written a white paper about the standards of care, how they would like to see the standards of care we do in the hospitals. Now, as said before, parents become very strongly empowered, telling us what they like to do. And I think there comes a time that we can't possibly exclude parents anymore in any discussion, in any decision-making processes along the continuum of having a child in the pediatric and neonatal intensive care unit. So we don't have to work on the empowerment of parents. The parents do it themselves already. However, across the world, there's an enormous difference. If you look at the visiting policies in pediatric and neonatal intensive care, is that we don't tend to talk about visiting policies in pediatric and neonatal intensive care in the US and in Europe. We would say you are welcome for 24 hours. So that's a start. Now, in many other countries in the world, is that there are limited visiting hours for parents, just a few hours to none. However, there's a trend toward opening more and more. Now, having the visiting hours coming open, that implicates that we need to communicate with the parents, and I think that's where the basis is of the inclusion of the parental involvement in end-of-life decision-making when difficult decisions have to be made.
So we have become a much more global society with many different end-of-life needs. And it's understanding those needs at times that can be difficult because they differ from our own. And as clinicians, it can be hard to reconcile. What are your recommendations regarding that?
I think it's a challenging question what you addressed. So let me start first that I do believe limitation of treatment does not implicate limitation of care. Now, keep that in mind and transform that to our clinical practice. And one of the recommendations I think is, and the importance is, that we should have show empathy to parents in any process of care we are, even from treatment till the most difficult decision making, all the way till the child is dying at that moment. Because if you look at empathy, definition of empathy is that I am able to recognize your feelings from somebody else. I believe that is what we should do constantly throughout the pathway, to assess the feelings, how the parents feel, what they actually want, and that empathy level of nurses. It's quite difficult. I mean, can you learn empathy? I would say possibly yes, because in various nursing curriculum they have empathy as a module in it, and there's also the Jefferson empathy, physician's empathy scale available to test actually the level of your team of empathy. But basically the recommendation is be as empathic as possible while defining the individual needs of the parents and the family members.
So we've talked a lot about the past and what brought you to your interest in end-of-life care and the present, but I'd like to hear about the future and where you see end-of-life care in 5 to 10 years. Where would you like to see end-of-life care in 5 to 10 years?
Well, if I would have a global ball to look at, and indeed I would love to forecast what's happening. I might forecast that, as I addressed before, we will have more interventional studies looking at specific issues in end-of-life care pathway, from the early discussions on till the follow-up care. Ideally, I would like to see the end-of-life care practices from a nursing point of view, that we have a more rigorous nurse-led follow-up clinic to support the parents in their bereavement, to support the parents on the longer term, what's happening. We've done a study among parents from Muslim background, and we figured out, it's a qualitative study, interviewed three parents, and we figured out actually during the recruitment of the study that out of the 21 eligible parents, most of them did not want to participate, just because simply they, in their religion, they believe that it's done, it's over, I continue. Whether that is a religious cultural implication, we still don't know that. Because if you look at the study, we looked at the care practices around death in the NICU, the World Survey, is that in Saudi Arabia, colleagues would say the rituals around that, it's a culture that parents are only informed when the child died. So there are so many cultural differences, I believe. But in 5-10 years' time, I would like to have not only a certain increased body of knowledge, but also intervention studies, which mostly best likely to be implemented in a larger group of parents. However, I always have to say however, because I believe it should be individualized. The number of cases we take care of in end-of-life care are limited compared to those who survive the PICU and NICU. So individualized based care is the most important way forward. And the last topic, I would hope for the next 5 to 10 years to have a better care for the grandparents, the siblings. Because we talked about parents for quite some time during this time. There are some recommendations how to deal with the siblings, how to guide when one of the brothers and sisters is dying, yes or not. There are several books available. I know in the Dutch situation, in the English situation. So there are several guidance and literature available for that. But don't forget, it's not only about parents only, it's the whole family dynamics where we have to look at. And for me, it would be great to see in 5 to 10 years' time that we take care of the whole family dynamics. And at certain levels, possibly we have to look at critical junctures in the pathway of a child dying in the intensive care unit, where we would have a sort of recommendation to look at and what to do during every critical junction with parents or siblings or grandparents. Mm-hmm. So basically, yeah, we have still some work to do. Thank you very much.
Thank you. Well, thank you, Professor Latour. We really appreciate you sharing your experience, your expertise, and your time with us today.
Okay. Thank you very much.
Thank you.